Hello, welcome to Facebook Live from CGH. I am Dr. Bill Bird, and this is Dr. Corrigan, who is one of our radiologists who's with us here today. Hi, Dr. Corrigan.
Hello. Hi.
Glad to have you. So it's going to be a little bit different thing today. First of all, we have multiple folks in the room. That's why we're doing the mask thing. We're doing a little different just to kind of make sure we're following all the right policies and procedures. So because there's more of us, we're going to keep our masks on, which we don't normally do during these broadcasts. The other thing I wanted to hit on before Dr. Corrigan and I start getting into what we're going to talk about is just we've had some people have been asking because at Lynn Boulevard, which is one of our clinics here in town, we did end up shutting that clinic down late yesterday afternoon. It was done out of an abundance of caution because we had at least a couple of the workers there who ended up testing positive for COVID. And so we're going to take the weekend. We're going to reopen on Tuesday. We're going to take the weekend to do all the deep cleaning that you need to do just to make sure things are good. Everyone there is being tested. The thing that I just want to reassure folks about is what we're seeing here at CGH, I don't think is unique to other hospitals, is that the folks that seem to, the exposures that we have are not, I could never say never, but I don't remember like a patient to staff or staff to patient type of situation, because when I go in a room to see a patient, I'm always wearing a mask, the patient's always wearing a mask, and so I think from a standpoint of patients going and seeing people at Lynn Boulevard or anywhere else, I think that's a safe spot. Where we're seeing the issue is when staff have like breaks and they have to have lunch. Those kind of situations, when they are having moments when they're not as social distancing or not wearing the masks, that's when we're having some issues and we're having to work through those. But I just wanted to just be upfront about that. That's a situation there. I know we've had some patients ask, well, how come no one's reached out to me? And how that works is how it works in any situation is that is in the hands of the health department, and they interview the folks involved, and if anyone needs to be contact traced, then they will get a call from the health department. I think I think the vast majority of patients, if not all of them, I don't think you're going to get contact traced because you were interacting with the staff and they were wearing a mask and you were wearing a mask if you were at Lynn Boulevard in the last few days. But yeah, that's what's going on with Lynn Boulevard, and I just want to be upfront about that. And of course, I'll entertain any questions during this broadcast. What I'm going to do, because this is a kind of try to improve women's health with a new and improved mammogram machine. I think what I'll do, and I didn't even talk to the folks about this who are in the room here, but I think we'll go through this program here, and if there are other questions that pop up that are COVID related to other stuff happening locally with COVID, I'll be glad to answer those, and I'll do that after all the folks here have done their thing. So, hope that was helpful. Tried to make it at least helpful. Welcome again, and we're going to talk a little bit about women's health, breast health in particular. And we have a new piece of equipment that's going to be making its way here to CGH. I have heard it called different things. I think for the point of this broadcast, we're going to call it a 3D mammogram. How's that? Is that fair?
Sure.
Okay, so there's the fancy word that sometimes the folks in Dr. Corrigan's world use is tomosynthesis machine, but we're going to use 3D mammo. And my first question for you, what's the difference between like a 3D mammogram that we're going to be getting and what traditionally you've used in the past, the 2D mammo?
Sure. So the 3D mammogram is actually...
They're probably going to want you to speak up.
The 3D mammogram is actually the most advanced form of...
I'm going to move it towards you. She's a soft speaker.
3D mammogram is the most advanced form of breast imaging that we currently have. It's very similar to the digital mammography that we currently use, as it utilizes X-ray technology. The only difference is that currently the screening is done by imaging the breast with 2 angles versus with the 3D mammogram, multiple angles of the multiple angles are utilized, which allows us to get more images of the breast. So, and this is done at a computer, so the computer will generate the 3D imaging. So basically, right now we have 4 images that we analyze during screening mammogram, and with 3D mammography, we will have an average of at least 300 images for both breasts.
So 300 images. Now, what are you getting for right now when you do a mammogram? How many images do you have?
Four.
Four?
Screening mammogram is 4 images,
Okay.
2 images for each breast.
Okay. So that's a lot more information.
Exactly.
Okay.
Hello,
Hey,
everyone.
hi, Dana. Dana's
How are
going to help
ya?
us to give a little more noise to this.
I am.
All right.
Keep talking.
No, I just think that's fascinating to go from 4 to how many?
An average of 300
300.
images. It depends on the breast thickness, so
Yeah.
some that will generate more images, but that's where the key and the essential difference between this imaging lies, because it will allow us to look at multiple slices of the breast. And
Yeah.
currently, because we are looking at a limited number of images and a 3-dimensional structure is compressed, it's very difficult for us to say, is it breast tissue or cancer, because they can both look white or look the same on a mammogram. But by having multiple slices, like pages of a book, we can go back and forth and see, is it truly a lesion there, or it's just breast tissue that on that one slice was confusing or confounding on this screen.
So in some ways, it's not a CT scan, but in some ways it has that same kind of technology that's utilizing.
Yeah, it is roughly, you can compare an X-ray with a CT. So what we're doing today is the X-ray of a breast, and what we'll be doing will be the CT of the breast.
That's a great analogy.
So we can actually see that visually we do have that ability to really see the 3-dimensional structure now. And to go back and forth and to really analyze the lesion, the margins, and a lot of other features that first will help establish if there is truly a lesion there, and then is this lesion concerning or not. And that's where it decreases the callback rate, because right now, in order for us to clarify is it truly a lesion or breast tissue, we would bring the patient back for a diagnostic mammogram, most likely more images, more mammogram images, and sometimes an ultrasound as well.
So before we get into that, sorry to interrupt you, just to hammer home this analogy again, which I think is really fascinating. So for those of you out there who are listening who've had, like, let's say a chest x-ray, do you think about that? That's this side and this side. I mean, it's usually just 2 views. You're getting a couple views, and that's that. And when you have a CT scan, you're having hundreds of little slices through your chest, and they can look at different directions. That's what we're talking about here with this 3D mammogram. So very interesting, exciting technology, and it makes sense that people like Dr. Corrigan who read these are going to definitely have more information.
Absolutely.
Does the data suggest that you would be able to find cancers potentially earlier with this piece of technology versus the 2D mammogram that you have been using?
Right. So this technology has been available since 2011, and there is ample scientific evidence both in Europe and in the United States that there is increased detection of cancer, especially invasive cancers, by an average of 40%, and also increase of smaller cancers. So we're able to find cancers much earlier than with screening mammogram, and this is very advantageous, especially in women with dense breasts, because again, dense breast is white on mammogram and cancer is white on mammogram, so it's hard sometimes on screening mammogram to distinguish if there is cancer or just breast tissue. And unfortunately, women who are younger have dense breasts and more invasive cancers, so this would be a patient population that would definitely greatly benefit from 3D mammography. All women will, but especially women with dense breasts.
Yeah, that makes sense. And you started talking about this, but I wanted to kind of get to this too, is so the typical way that we've done it in the past is a woman comes in, has a screening mammogram, and then you take a look at it, and maybe that day or the next day you take a look at it and say, okay, I have some concerns here, and we need to do what's called a diagnostic mammogram, which then they come back in.
correct.
So how's that going to play out with this? Have you guys talked that through with this new machine? How would that change that process?
Sure. So in most cases, what would happen is, as the literature suggests, is that when you're seeing this dense spot, you can go back at those images, back and forth at the slices, and confirm that this is truly breast tissue. So there will be no need to call the patient back. Normally, we would bring the patient back for compression, additional images, and you would hope that with compression, breast tissue will spread out, or the image just by itself would look different the next time around. But if it's truly a mass there, it will not go away with compression, or even with a slightly different mammogram, it will still persist. But this would be clarified already with 3D mammography, just because you have multiple images to look through, and so you'll be able to distinguish if it's truly a lesion or breast tissue. And then if it's a lesion, you'll be able to assess the margin and other features which will help you distinguish if it's a benign lesion or a malignant lesion.
Okay. So there'll be fewer diagnostic tests that people are having to come back for.
Exactly, right.
You know, some ladies will have, that are watching or know someone who had the mammogram and then they had to do an ultrasound or an MRI. Will that change that in terms of whether we do those kind of things?
Sure. It will actually, this is very patient dependent. So most of the time, where we decrease the recall rate right off the bat at screening, because you already see this is breast tissue, so these patients are not going to be coming back at all. Now, if you're still confident that there is a lesion there, and if it's a benign lesion, you might still need ultrasound to confirm that it's a cyst. And if it's a solid lesion, you'd still need ultrasound to confirm and then proceed to biopsy.
Okay.
But really, the 3D mammogram is not, it's going to decrease patient coming back to the department at all, just because we do bring...
so you'll still probably have similar numbers of ultrasounds.
That's correct, because these modalities
MRI,
have their own advantages in what they what they can do. For example, in a young patient, younger than 30 years of age, if she comes with a palpable lump, ultrasound is still the imaging modality of choice, because we don't want to expose the young breast to any radiation. And same thing with MRI, it will be beneficial in the extent of disease. Once we establish that the patient does have cancer, it is beneficial in some patients to still get the MRI to see, even though 3D mammography has been shown that it is better at finding multiple cancers, or at least is suggestive of that, but still there is use for MRI prior to treatment to check both breasts.
Good.
For extent.
What are those newer light bulbs that are supposed to last longer? LED? I think your office has those in there probably. We need those in there for you, because if you're going to be reading an image that has 300 images instead of 4, we're going to have more lights. You're going to have to be here longer. You're going to have to spend more time reading those, I would think.
Yes, for sure, right. So that's a downside for us as radiologists. It will definitely take longer, to review 300 images versus 4. But it's really what's best for the patient. I feel that this will definitely help our diagnosis, and improve the patient experience and then decrease their anxiety, and minimize their rate of comeback as well as cost. Yeah,
good. Well, that's a lot of stuff from Dr. Corrigan. Do we have a question, Dan? Let's see here. Oh, that was for my wife. Sorry. Let's see here. I'm so looking forward to having my mammogram with a 3D, because my past mammograms have all been dense breasts. And then, so that's more of a comment than a question, but yes, you agree.
That would be a patient that would definitely benefit from the 3D.
Right. And then, will all mammograms be with a 3D machine?
Yes. Mm-hmm. Because that's, again, the machine will have the capability to do what we're doing right now, and then extra. Yeah. Right.
So, good question. All be 3D. So you'll be in 3D when you have that mammogram done. All right. Anything else that I should have asked you that you're thinking about that I should be asking you before I let you go?
No, I just want to make sure and reassure all patients that if they have a concern about radiation, because we are doing something extra, and this is X-ray technology.
Good question. Yeah.
So there is a very little amount of radiation. initially with a screening because we're taking more images, but this is really negligible. First of all, mammography is very strictly regulated by the FDA, MQSA, American College of Radiology. So we do follow, protocol, and we're always with the guideline with radiation. But this new technology will increase the radiation dose to the woman by twice on average. But this is comparable to 2 months of background radiation.
Okay.
So what
Yeah.
we normally would get, from background, similar to, like we said, an X-ray of the chest. So the 3D mammogram will provide a radiation dose that's comparable to 7 weeks, 2 months of background radiation. So really very negligible for all women with mature breasts, which we image greater than 40. Again, where that becomes an issue is in younger patient populations where
Sure.
we're very cautious with utilizing mammography.
Good. Appreciate Dr.
Thank
Corrigan.
you.
Thanks for
Thank
being
you.
on. And while she makes her way out and her chair leaves and Erica comes in, I'm gonna these shirts. So I'm not wearing a bow tie today because the director of the department told me I had to wear this shirt. No, I bought this shirt a while back. It's a what was the it was for breast cancer month or
Breast
what?
Cancer Awareness Month last
Yeah.
year.
Yeah.
For a fundraiser.
Yeah, come a little bit more towards me here, Erica. Thank you. So, yeah, and it says "Fight like a Wonder Woman."
Yes.
Is what it says, right? Yeah, I know it says that because I looked. But anyhow, yeah. So you can probably are these shirts still for sale? Joan sells anything that she can get her hands on, and she'll.
We're selling new ones.
We have new
We have
ones.
new
this
ones.
year.
Oh, we have new ones. So yeah, if you're like, wow, that looks really good. Well, I'm sure it does, right? I mean, we look great in these. Anyhow, if you think this looks really good, just wait till Joan comes out with her next one for the foundation. It's going to be even better. So there you have it. All right, Erica Adams.
Yes.
Glad to have you here.
Thank you for having me.
So Erica is a nurse navigator in our diagnostic imaging X-ray department. And yeah, so she's been at that gig for a few years now, haven't you?
About 5 years.
Okay.
Yep.
I'm going to say few is about 5, so I was right on that. All right, so Erica, I want you to explain for those watching how your role as a nurse patient navigator fits into our current mammogram process.
So first, the patient's process starts with our amazing imaging center, Women's Imaging Center, with our mammography techs. Some of you may know them by name: Janelle, Lacey, Shari, Carrie, and Kelly. Without, obviously, those girls, we wouldn't be able to have quality imaging to detect cancer. So the patients get to start their process with them. Once they have the imaging complete, our radiologist, like Dr. Corrigan, who just spoke, looks at their images and decides if they need additional images in the event they see a dense area or if they see a calcification, which is a mineral deposit, that they need further workup on. That's where I come into play as a navigator. I contact the patient and inform them of the reason why they're being called back for additional imaging, and kind of educate the patient from that point what the reasoning for their callback is, so that way it can kind of alleviate a little unsettledness being a callback and having to come back for additional images. Once that patient comes back for the additional images, again, they'll meet our mammography technicians again and maybe our ultrasound department. After those images are completed, they show those images to our radiologist. The radiologist at that time will determine if the patient just needs to be come back in 6 months for a short-term follow-up, or if there is a lesion that needs to be biopsied. If the patient needs to be biopsied, again, myself and the radiologist will sit down with the patient and educate them on what the radiologist is seeing and what the recommendation is, and then at that point I set them up for their biopsy and get them scheduled in a timely manner.
Okay. So you're basically with the patient from the moment they begin this process of having a mammogram until whatever happens, happens.
Yes.
Okay. Which is nice. So you've got that going for you. What movie's that from?
I don't know.
Caddyshack.
Caddyshack.
All right. So anyhow, Dr. Corrigan was talking about how with this 3D mammogram, they're not going to need to do as much of this diagnostic thing later. So how does your role change? How do you foresee that being different?
So I see that role changing as possibly starting my role sooner because hopefully we're detecting them sooner without additional imaging, because with the 300 additional images, she doesn't have to have that callback because we have those images. So therefore, my role as being their navigator and kind of breaking down any barriers to a timely manner scheduling, that's going to remain the same. But as far as getting to meet the patient sooner, I think that's what's going to be different.
So that day you'll be available to kind of latch on to that patient and say, hey, here's what we've learned so far, here's what we need to do, that kind of stuff.
Yes, we'll see you next year because you graduated, or we'll see you. We need to talk about what the next step is.
Yeah, I'm assuming that they would still have to come back on some latter date if it's determined they need to do a biopsy.
Yes, but the education can take place sooner than later.
Okay.
And get them scheduled sooner than later. So those things may change logistically, but my role should stay the same.
Good. And so I know, fortunately, most of the women who have abnormalities on mammograms, it ends up being okay. But there's a certain percentage of folks who it's not okay, and they do end up being diagnosed with breast cancer. And the question I wanted to run by you is that we do have. So if you end up having to have treatments of some type or form, and you end up in our oncology office with Dr. Ali Khan, who, by the way, is outstanding, and we're so glad to have him and his team. Wouldn't hesitate one moment if I had a loved one who had this to go and see Dr. Ali Khan. He has a nurse navigator, Sue Hageman, who kind of takes on who's involved with the cancer patients and kind of making sure that the flow of their care goes well. So do you guys have like a handoff when they go from where you're at in your department and they end up with Dr. Ali Khan and Sue takes them on?
Yes, we actually are. Sue and I are very close and talk very frequently. After we sit down with the patient and go over their results, and there unfortunately are positive, we set the patient up with a surgical consult at that time, but we also make sure that they know that just because they have a breast cancer doesn't automatically mean they have to have chemo or radiation. Right. But we always still refer them to Dr. Ali Khan just because it is a cancer diagnosis. So after I meet with the patient and the patient leaves, I'll let the patient know that, hey, my role, I'm going to hand off to Sue Hagerman. I give her the card, contact information. If there's any questions that I can't answer that's more geared towards oncology, she will be happy to answer for the woman.
Yes.
So after that appointment, I will call Sue and say that this patient, XYZ, is going to come see a surgeon on this day. This was her diagnosis. She's really nervous, or she's really fun, because I get to know these women on a personal basis. So I kind of want to do that handoff to Sue, which will help ease the patient's fear. Oh, she kind of already knows me because of Erica.
Right. And
so we do communicate very frequently with one another about our patients. Okay. And like I said, if there was a question I don't understand or know, I can tag her and vice versa.
Okay, yeah. So you may not have understood all that was going on, but just know this, that once you come here and have your mammogram, you're going to have a nurse stepping right alongside of you throughout this process, whether it ends at the end in our diagnostic imaging department with a mammogram biopsy, or whether it ends seeing Dr. Ali Khan and his team in oncology.
So yes, we follow them through their entire journey, however small or large that could be.
Okay, great. What's the favorite part of your job, Erica?
I love my job. I really, truly do. When my mom was diagnosed with leukemia many years ago, I wasn't working in this role. I was a surgical nurse. Mm-hmm. So when she had to go to oncology and all these other appointments, it seemed very overwhelming for myself, because she was looking at me for answers and I didn't have them. Mm-hmm. So we didn't know who to call, who to contact, and I remember the frustration of that. So now that I'm here as the navigator, I can see other family members potentially not having that barrier, because myself and Sue and all of our diagnostic team are very knowledgeable, and we can streamline that whole process. So even if I'm not the right person to call, they can at least reach out to me, and I can get them to where they need to be, or get the right people in the room to answer any questions or eliminate any barrier that they may have. So very compassionate about my job. I love it. I love my patients. I get very personal with them. A lot of them I've had relationship outside of here but we met here. Mm-hmm. So
Good.
Yeah.
Good. Well, I'm glad I asked that question. Hey, Erica, great job. Great to have you on. And I'll let you go.
All right.
All right. Thank you. All right. And the next contestant on. So, hi, Gina.
Hi, how are you?
Good. This is Gina Grennan. Gina Grennan is the director, the manager of the diagnostic imaging department. And before I go any further with Gina, I feel like I haven't done as good a job as I should of telling you why we have all these folks.
Oh, you're on.
Hello again. We had some connectivity issues, as does happen on occasion. But we're so glad to be back with you. And before I get into the question I have for Gina from all of you, I had a comment about Erica. Erica's still in the room, so she can hear this. This viewer said Erica is awesome, all caps, is an awesome navigator. I am a repeat customer too. To their department, and everyone in the department makes the whole experience a lot less scary. Great job, Erica. 2 exclamation points as well.
Thank you.
Good job.
Good job, Erica. Okay, so hey, Gina.
Hey.
First question that came in from one of our viewers was when. Okay, great. I love this thing. When's it going to go live?
That's the burning question, huh?
Yeah.
We're really excited. We've been waiting on this for a couple years now, and we should be live by the end of the calendar year, if not a little bit earlier.
Okay.
We are all hoping for an early Christmas present.
All right. So December, January.
Yep.
That'd be ballpark when it's
Yes.
going to go live.
That's a very good ballpark.
All right. So one of the other things I wanted to ask you, Gina, kind of the big picture person, this is pretty impressive stuff.
Mm-hmm.
How do you guys kind of keep up on all the current trends? And so just rattle off the things that you guys are oversee in terms of different imaging.
The different modalities that we oversee are general radiology, which is your plain film radiology, fluoroscopy radiology. We do pain clinic, we do CT, nuke med, ultrasound, mammography, DEXA imaging. I know I'm forgetting somebody.
I know.
But we
MRI, all that good
MRI,
stuff.
just
Yeah.
give you an idea, we have 80 to 85 employees in our department, and of those employees, everybody specialized in a different area.
Or modality, as you would say.
We call them modalities. Yep.
Yes.
Yep.
Okay. So how do you guys keep current on all this stuff?
You know, really, it's a group effort. It takes all of us, between myself, the supervisors, the radiologists, frontline staff, specialty areas. They keep up with their own trends in their own areas. But really, from our governing bodies, professional groups, like Dr. Corrigan had mentioned, the American College of Radiology. I personally am a member of the Association for Medical Imaging Management, and we do trade shows like RSNA, where there's education along with the vendors there to let you touch and feel the equipment. So it's a group effort. We're all required to get continuing education. So in that continuing education, a lot of the times we're educated about the new and up and coming. So all these things take us back and connect us with the global radiology world to make sure we're at the forefront of imaging.
Yeah, and they really are. Gina's had me go the last couple years to this conference. It's, I don't know, RSNA is there.
Mm-hmm.
But if you've ever been to McCormick Place, like they fill that place up.
Yeah.
It's crazy. All the vendors and all the different kind of imaging stuff that new and improved, and so yeah, it's really impressive. And that's one of the ways that they do a good job of just kind of keeping on the cutting edge with all that stuff. Yeah, I think it's really impressive. So speaking of latest and greatest, because you can have a CT scan, and then you can have a CT scan.
Yep.
And same for all these kind of imaging modalities. How does CGH compare if you were to have a continuum of, we got it before the Soviet Union, went down, to we got the latest and greatest 2021 stuff. Where are we at with that?
I honestly, and I'm not just saying this because I love radiology, but we really shine in this area. Our facility stands apart compared to other rural hospitals. You could probably compare us more to a larger medical facility. Besides the oncoming 3D mammography, some of the stuff that we offer on site with equipment and technology are on site PET scanning.
So that's like if you're looking for a little cancer throughout your body with an MRI.
Yeah, most people that live in rural areas have to go elsewhere to travel to get this scan done, and the fact that we offer it in-house is amazing. We have a new, I don't know if you call it new anymore, but 2-year-old vascular OR lab that Dr. King practices in along with Dr. Song. State-of-the-art equipment. We're able to do stuff that only larger facilities can do. So to have those pieces of equipment here are amazing. In addition to the equipment, we offer services that other rural hospitals can't offer. On-site radiologists, I cannot tell you how lucky we are to be able to perform interventional radiology procedures right here in our community that people would have to go elsewhere to get.
Yeah, sorry to interrupt, but what she's saying is that like a lot of places, their radiologists read from they're sitting on a beach in the Caribbean, reading your imaging, which you can do it.
Yeah,
that's the technology allows you to do that. But our radiologist also, if you needed to have a lesion on you have a nodule on your lung, they can take care of that here.
Yep. We biopsy, we do drainages, even just having face-to-face consultation with the ordering providers to be able to make sure that we're getting the best care for the patients. Having a navigator, having Erica here, that's huge for patient care. And then we're lucky to have our Health Foundation, who you had mentioned is helping with this project. They're helping tremendously, and not only are they helping with the capital purchase of this project, but they also help on a daily basis where they offer free women's services. So they take that financial barrier right up front. We want people to get screened, and they've worked alongside of us for the last couple of years to make sure that no woman feels like they can't come in to get their screening. And they've committed to do that even after we get the 3D tomo imaging. So those are just a snapshot of the things that we offer that you can't get other places.
Shout out to the foundation, do a great job, and that's one of the ways that they support the hospital for sure. There was a question about will training be done, new training be done, I guess, for folks that are going to be using this.
Oh, absolutely. We would never implement a piece of equipment without that. So along with your purchase, you get what we call applications training, which includes training for the radiologist on reading this specific type of mammography, and then in addition to the staff that's using it. As Dr. Corrigan mentioned, it's highly regulated by the FDA, MQSA. So there's a lot of things that we have to be compliant with. So to you on the outside, you might think we just put a piece of equipment in and boom, we just know how to use it. There's a lot of training that goes into that. So you can be assured that the people that are doing and reading your exams are highly competent.
Yeah. And I typically ask managers about this during this pandemic, but can you just kind of speak briefly to what you guys are doing in your department to try to make sure patients and staff are safe throughout this time?
Sure, absolutely. I think it starts with education. We're fortunate enough here to have an incident command committee that keeps up on the facts-based information and the recommendations on what we should be doing. I know you've mentioned on your Facebook Live, this is a very fluid situation and things change. Employees are very adaptable, but it's ever changing. It starts with scheduling the patient. Our central scheduling department will go over some screening questions with the patient and or the office is scheduling the patient, and then right physically when the patient gets here, they're screened. We make sure that they're properly masked, their temperatures are taken, and then we place them in a waiting room. Some of the things we've done to accommodate the social distancing is we have physically put alternative waiting areas in place to make sure that patients feel safe, they're social distance. After the patient goes to their imaging modality, somebody is right behind them cleaning that areas to make sure it's set the proper time to disinfect before the next patient comes in to sit down. So really, education, masking, hand washing, social distancing, disinfecting, cleaning. A huge shout out to our environmental services department. If we have a room that needs to be cleaned, they come in and they put the UV robot in there. It is a higher level of disinfectant. I think we're just all being diligent about doing the things we're supposed to be doing to make sure that you're safe when you come in here.
Yeah, it goes to what I was saying earlier in this Facebook Live, is that we feel like in terms of patients and staff, and we interact with each other, and we've got that locked pretty good. We're still working on when we're in our break rooms and those kind of things, but
yeah,
I feel pretty. I mean, your department's doing a really good job of keeping folks safe with that. So good.
Definitely safe to come in and have any study done here.
Yeah, and I would say probably in terms of our volume, it's probably the same as it was, or if not more than it was before this pandemic hit.
Absolutely. Some of our modalities are busier now than we were before. Obviously, we're catching up a little bit from the routine outpatients, but it makes me feel good to know that people feel safe to come into CGH.
And they should. So, I wanted to ask this question, and I'm just kidding. I had one. Gina and I work really closely together. I'm her VP, and she's one of my managers, and she does a great job, and she does a great job running that department. So, Gina, thank you. Just thank you in general, but I also thank you for kind of getting all this stuff going and being part of making this 3D mammogram a reality. So
yes, we're super excited.
Yeah.
Thanks for having us.
Yeah, thanks, Gina.
All right.
So I have Lindsay Pistol. Love the name. Come on over here, Lindsay.
Hello.
Hey, Lindsay. So
Hi.
I'm going to give Lindsay the floor in just a minute here, but Lindsay is with the foundation. Yeah, she's going to come a little bit more this way. All right. So Lindsay's going to kind of give you some information about an event that the foundation is hosting, and I'll give you the floor. And I'm going to step out just for a second. I'll be back in just a minute, and we'll talk COVID when I come back. Okay? All right.
Thank you. As Dr. Bird mentioned, I'm Lindsay Pistol. This year I am co-chair of the CGH Health Foundation Delicious Designs 7th annual event. So as you've heard here today from all of the other individuals before me, we're here to tell you a little bit about how we're going to fundraise for that item, the 3D Tomo. So my co-chair is Star Coleman, and she was unable to be with us today, but this year we're kicking off the event with an all virtual look. So I'm sure you guys have seen that everywhere you are. Maybe yourself, you've had to do things differently. I know myself, I've had to do things differently in my own world, my own job. So everything that we do this year will be virtual. Normally our event would have been in October during the 3rd week, and we would have had that in person, but this year you'll see that as a virtual event. So proceeds from our silent auction and sponsorships for our wish list items are going towards the 3D Tomo that you've heard about here today. Also, it's going to go towards breast health services items. So Star and I are so honored to be helping with such an important event in the Sauk Valley area that will go towards the women in the Sauk Valley area. So we're very passionate about giving back to this community. We both live and work here, and we're very much supporters of women's health. I know I personally haven't had an impact, which I've been very grateful for, but I know Star has, and she has shared that with all of us here. So we're very proud to be able to give back to that event. So the foundation's goal, as you've kind of heard here, is to support that item. So $100,000 is the goal to be able to give towards that new equipment. And all contributions to our event this year are matched dollar for dollar by a generous donor. So the past support of all of our prior attendees to this event is going to be a major factor to the success of the overall goal. So we're just reaching out to everybody to please join us virtually for this event in support of breast health services and the new 3D Tomo. So you may be asking, what are some things that you can do to help? You can sponsor a wish list item in honor or in memory of a loved one who has been impacted by breast cancer or other cancer. That site will actually go live here today. There are some items on there already that you can take a look at, and by the end of the day that should be ready to go. So you'll be able to choose from any of the items. Those could be headscarves, turbans, gas cards, and all of those will be posted on the Delicious Designs page on the CGH website. I'll go ahead and give you that, but just so you can see it a little bit clearer here, so it's at cghmc.com/deliciousdesigns. So for this sponsorship, you'll be able to give a donation from either $5 to $100, and you'll be able to do that donation towards those items that will go towards area women. You can also do a pink ribbon tribute. So what that will be is you will get a small pink ribbon, kind of similar to the one that you see on here, and you can do that in memory of a loved one, or in tribute or in honor or in memory of a loved one. And those will actually be posted to the CGH Facebook gallery, so you'll be able to see that out on the Facebook page. So starting on October 15th, you can actually begin bidding on our silent auction items. So you'll be able to preview those baskets the day before on October 14th by clicking a link on the Delicious Designs page on the CGH website. On here, you'll be able to find gift baskets, experiences, different services, yummy desserts, gift cards, all sorts of items will be on there for you to take a look at and to bid on. So we're still continuing to look for donation items for that. So it could be a basket item, a gift card, a dessert, if you're interested in contributing an item to that. So you can contact me directly at 815-878-764, or you can contact Star Coleman at 815-441-9623, or Joan Hermes at the Foundation office at 815-625-0400. Online bidding for this event will begin at 7 a.m. on Thursday, October 15th, and that will run 24/7 until 5 p.m. on Wednesday, October 21st. So again, that's a lot of information there, a lot of things that you can see and hear. Again, you can find these on our social media pages. So you'll be able to follow our CGH Facebook page. You can like the event, you can invite your friends to the event, share it on your page, and get the word out there. You can check out more details on this again by going to our website, which again is here at cghmc.com/deliciousdesigns. That will kind of recap everything for you. Again, that's a lot of information being thrown at you there in just a few minutes, so you'll be able to see all that information. You will see us again over the next weeks leading up to that event. You'll see Star, you'll see myself, any of our members that are helping here with the virtual event. You'll be able to see the way, so we'll be popping in, showing you some items, just touching base to let you know how things are going. Anything that's being be able to be updated on as you watch all of that virtually with us. Listening to a little bit about our event, and we'd be really very grateful for your support this year. Again, it is virtual, so please keep your eye out, look for us, look at our Facebook pages, and please share the word for us. We are stronger.
Thank you, Lindsay.
Yes, thank you.
I know I've been to that Delicious Designs event when it was live. I'm telling you, they suck 66 positive cases in Whiteside County. So, I think the census is somewhere in that 50,000 range. So if you did the math on that, 1 in 50 people have been positive for COVID. That's about 2% of our population. So, if you just walked around town, you can run across 50 people pretty quick to give you some sense of it's definitely out there. And we've definitely seen, Rebecca Green sent me something. And, thank you. What we got here? Okay, yeah, so I saw that from Rebecca too. 6.9% positivity rate. So like lately, 6.9 patients that we've tested have been positive. We've had 55 new cases since this past Sunday, August 30th. 15 of those 55 cases are 60 and older, and I think 12 of them are under 20. So I think it's a combination of, some of the school stuff getting going here. You're starting to see that. You're just starting to see more cases pop up here in the area. So we don't have to be alarmist about this, but boy, we need to be smart, continue to be smart about when we go about our stuff outside of our homes, that we wear a mask when we're out and about, and we try to keep distancing and those kind of things in play. Because that's the kind of stuff that keeps. Once again, I never say never, but the vast majority of folks that I hear about that became positive were typically in one of those kind of bigger group situations without masks, without social distancing, and that typically gets the vast majority of our positive tests. So if you're not doing that, you can, by and large, go about your business, and I think you can do pretty well for yourself. So, and 6.9% positivity rate, 2 regions in the state right now where they're still in phase 4, but they've backed away some stuff, like how late the bars can be open and the people can't be inside bars, like around the Illinois side of St. Louis. And just south of Chicago, like Joliet and that area there, they've kind of gone to those measures. So, and I think 8% is kind of that number of positivity, where if you have, I think, 3 days in a row of that, the governor will start making those mitigation efforts, put those in place. So we're not there yet, but gosh, I would encourage folks to kind of follow the right stuff to try to keep us from being there. Good news is we're not like in Iowa City or something. I was looking on, gosh, I think it was like New York Times has this nationwide positivity stuff. They kind of run it. I think right now our per 100,000 people, I think we're in Whiteside County, like, are we at 17, 20 per 100,000, something like that? I really think I saw that it was like over 200 in a couple counties over there in Iowa. So we're wearing a mask and distancing makes a big difference, because when I've been over in Clinton and those kind of things, you don't see that as much. And